Hello friends, today we are learning about oral rehydration salts. Diarrhea is a major cause of mortality in infants and young children, primarily due to severe dehydration and electrolyte loss. The discovery that intestinal sodium absorption is coupled to glucose transport revolutionized the treatment of diarrheal dehydration. Oral rehydration salts therapy is a simple, cheap, highly effective and physiological intervention that saves millions of lives globally. Pharmacological basis or mechanism of action. The entire rationale of ORS is based on a sodium glucose cotransporter 1 SGLT1 located in the apical membrane of the mature enterocyte during secretory diarrhea. For example, cholera. The cholera toxin stimulates CAMP, leading to massive secretion of chloride, iron, and water, while inhibiting the normal sodium and hydrogen exchanger. However, the SGLT1 importer remains completely unaffected by these enterotoxins. This importer requires both sodium and glucose to be present in an intestinal lumen to function. They are transported together into the enterocyte in 1 by 1 ratio. When sodium and glucose are absorbed, it creates an osmotic gradient, causing water to flow passively through paracellular pathways and aquaporins, effectively dehydrating the patient. Important Viva point: why not just give glucose water or plain salt water? Because glucose alone cannot be absorbed efficiently without sodium. Sodium alone is not absorbed because the normal sodium channel are inhibited during diarrhea. Only the couple sodium and glucose transport remains active. Composition of WHO ORS. In 2002, the WHO and UNICEF recommended a new reduced low osmolarity ORS. The older formulation sometimes caused osmotic diarrhea due to high sodium and glucose content. The new formulation reduced the need for intravenous fluid and stool output. In a new ORS, there is a reduced amount of sodium chloride and glucose anhydrous. Total weight is also changed in a new low osmolarity ORS, that is a 20.5 gram only. Ionic concentration of new low osmolarity ORS, which are solutes used in a new ORS, and what are the concentration, what is the role in ORS therapy. The sodium concentration in a low osmolarity ORS only 75 millimole per liter. Facilitates glucose absorption, replaces lost extracellular volume. Chloride ion concentration is 65 millimole per liter, which maintains electrochemical neutrality. Glucose concentration is 75 millimole per liter, drives the SGLT co-transporter, provides some calories. Potassium's concentration in a new low osmolarity ORS is 20 millimole per liter, which replaces massive potassium loss in diarrhea, prevents hypokalemia and paralytic ileus. Citrate concentration is 10 millimole per liter. Citrate corrects metabolic acidosis. Diarrheal fluid is rich in bicarbonate. Citrate is more stable than bicarbonate. Total osmolarity is 245 milliosmol per liter, which is hypotonic relative to plasma. Practical instruction for preparation and use. Preparation: empty the entire contents of the standard packet into exactly 1 liter or 1000 ml of water, which is clean, safe drinking water. Stir until fully dissolved. Storage: the prepared solution must be kept covered and consumed within 24 hours. Any remaining solution after 24 hours must be discarded due to the risk of bacterial growth in a glucose rich medium. Administration: dose given ad libitum as much as the child wants. After each loose stool, General guide 50 to 100 ml for infants, 100 to 200 ml for older children, and as much as tolerated for adults. Indications and contraindication of the ORS. What are the indication? When to use ORS? Mild to moderate dehydration secondary to acute diarrhea, for example in cholera, rotavirus, and E. coli. Maintenance of hydration status is ongoing diarrhea, heat exhaustion or heat stroke. Contraindication, which means when not to use ORS. In severe dehydration, when patient in hypovolemic shock, unconscious, or unable to drink, requires immediate intravenous fluid like Ringer's lactate. Severe intractable vomiting, oral fluids cannot be retained. Paralytic ileus, intestinal obstruction, severe renal impairment or anuria, risk where is risk of hyperkalemia, glucose and galactose malabsorption which is rare. Zinc supplementation, WHO recommends adding zinc 10 mg per day for infants less than 6 months, 20 mg per day for children greater than 6 months for 10 to 14 days alongside ORS. Reason zinc reduces the severity and duration of the current diarrheal episode and prevents subsequent episodes for 2 to 3 months by enhancing intestinal mucosa regeneration and immune function. What is the super ORS? Polymer based ORS, rice powder ORS, where 50 gram of boiled rice powder replaces the 13.5 gram of glucose. As starches are digested slowly, they release glucose gradually, preventing a high osmotic load in the gut lumen. This actually helps in reducing the volume of stool pass, which standard ORS fails to do. Why is citrate preferred over bicarbonate in new ORS formulation? Bicarbonate makes the powder hygroscopic, absorb moisture from air, and react with glucose, turning the powder brown, caramelization, and reducing shelf life. Trisodium citrate is highly stable, gives a longer shelf life, and is rapidly metabolized in the liver to bicarbonate to correct acidosis. Can we mix ORS in milk, soup, or fruit juice instead of water? No. ORS must strictly be mixed with clean water. Mixing it with other fluids alter the precise osmolarity, and sodium glucose ratio also can be changed, which can worsen the osmotic diarrhea. What happens if you dissolve the 1 liter packet in only 1 glass of water? One glass contain only 250 ml of water. When we add 1 liter packet on in 250 ml of water, solution becomes hypertonic. Instead of hydrating the patient, the hypertonic fluid will draw water out of intestinal cells into the lumen, severely worsening the dehydration and diarrhea. Thank you.